Okay. I should be able to do chapter 50 in just one video. This one shouldn't take too terribly long. This one, chapter 50, now we're going to talk about the biliary disorders, which basically is gallbladder and pancreas. It's still part of the hepatoportal system, but okay. Your gallbladder, as you'll recall, is just responsible for holding the bile that the liver has produced. So the liver produces the bile, stores it in the gallbladder, and then the gallbladder dumps it into the GI tract in the presence of fat, because the purpose of bile is to break down fat. So sometimes a person can develop cholecystitis, which is just an inflammation of the gallbladder, or cholelithiasis, which is stones in the gallbladder. In both cases, classic symptoms are, well, with cystitis, it's more, they'll have more of a fever, general malaise, that kind of stuff. And there you just kind of rest it and put them on antibiotics. Cholelithiasis is the development of stones inside the gallbladder, and what happens is somebody will eat a meal, usually a meal that's high in fat, and then a couple hours later they'll have distension, bloating, dyspepsia, and pain, because what happens is they've ingested high fat into their stomach, then the food starts moving into the duodenum, and then the body senses, oh, there's a lot of fat here, and it will compress the gallbladder to squeeze bile out, because it's going to try to start breaking down the fat. Well, when the gallbladder squeezes down, there's a bunch of stones in there, it hurts really bad. So that is a classic symptom that your patient has gallstones. So the treatment of choice, number one, is you tell them to avoid high-fat food. So, you know, just don't eat fatty foods, and then that gallbladder is not going to compress. Well, that works lovely if you have just one little stone. The problem is, if there's one stone, there's often several, and then they can't all get out, and they can sit in there and cause infections and sepsis and things like that. So when the symptoms become too bad, and when the stones become too bad, and you can identify it on ultrasound. So when the patient starts complaining of these symptoms that I just said, you send them for an ultrasound, and those stones will show up on ultrasound. And if there's a bunch of stones in there, they usually end up just taking the gallbladder out. The people that tend to have cholelithiasis, women tend to have it more than men, and it usually occurs in people who are over 40. You very rarely see this in younger people, and for some reason people that are women that have not had children are at higher risk for it. That's called nulliparous. You will learn more about this when you get to OB, but nulliparous, and I'll write this out on the board when we're in class, just means a woman who has never carried a baby to full term, and for some reason they're more prone to developing gallstones. Obese people are more prone to developing gallstones. Okay, so yeah, so the risk factors in chart 51 down at the bottom of page 1392 kind of show you some of the risk factors for developing gallstones. Oh, you know what? I think I said null. Did I say nulliparous? I meant multiparous, like multiple pregnancies. I'll explain more about that in class, but people who've had lots of babies. Okay, so some other symptoms, they can develop jaundice, especially if that if the common bile duct is obstructed. They can develop jaundice, pain. So usually what they have to do is surgery. I do want to point out what an ERCP is, and that's on page 1394. When patients start showing up with this, you know, it's called epigastric pain, which is pain kind of right in here, and the surgeons are trying to figure out which of the ducts are affected. And look down on figure 53. See how you've got the pancreatic ductal system drops in, the common bile duct and the gallbladder, the biliary duct, all kind of, they drain sort of all in the same area. Well, there's a procedure called an ERCP, and it's an endoscopic, meaning the scope that goes down the esophagus, it goes through the stomach and into the duodenum. Retrograde, meaning it looks backwards, choleangiopancreography, ERCP. And it's a little tube or a figure-like projection on the end of the endoscope, and it goes back up into the bile ducts to find out what is obstructed and what kind of damage they're looking at. And that's useful for somebody who has suspected significant cholelithiasis, pancreatic cancers, common bile duct or biliary duct problems. They can use that procedure. It's called an ERCP. It's really hard to learn how to do. So it usually takes quite a trained surgeon to be able to do that, or a GI guy. Okay, so once you you have a patient who has known cholelithiasis, there's a couple of options. There's some supportive therapy where you can just use rest and IVs and fluids and no high fat. If it becomes infected, they can use antibiotics, things like that. However, there are some other medicines that can help dissolve stones. So if the stones are small and there's not a lot of them, there are some pharmacological therapies like Actigol and Chenix. They dissolve the stones, but it takes a long time. It can take weeks to finally dissolve this. So they only use those kind of chemical dissolving agents if the symptoms aren't really significant. Usually what they do in cholelithiasis, if it's stuck in the duct, if there's a stone that's stuck in there, they can use that, the ERCP type device and go in and grab the stone and pull it out to dislodge it. That's like an intracorporeal lithotripsy, kind of like when I was telling you about kidney stones, how they use lithotripsy on there. But most of the time they do what's called a lap chole, a laparoscopic cholecystectomy. And there's a picture of it on page 1397. With a lap chole, what they do is there's 4 instruments that go into the abdomen. One's a light, one is a camera, one is a cutting instrument, and one is like a retractor, like to separate out the organs. And all they do is they usually put the patient in reverse Trendelenburg, so the head is down here just slightly. And the reason for that is it pulls the thoracic organs away from the abdominal organs, because the gallbladder is up under the liver. That way the surgeon can visualize the gallbladder a little bit easier. They do fill up the peritoneal cavity with carbon dioxide. The reason they do that is because it's like, making the person kind of gassy, and so it gives the surgeon more space to work. One thing that you have to do as a nurse is the next day after surgery, all that carbon dioxide, it starts breaking up, but there's big bubbles, and it'll go to the shoulders because the person's been on their head, and so their shoulders are really sore. So you can have them move their shoulders. You can put heat compresses on there. It kind of helps dissolve those larger carbon dioxide bubbles. And then what they do is they just go in there and just take out the gallbladder. And you know, there's really, that's the end of it. It's easy. They usually are in the hospital, you know, one day. Make sure, follow afterwards as a nurse, you just make sure that that there's no bleeding, that, you know, that their incisions look okay, and usually they don't have any other problems after that. You do watch for some complications can occur, like if they nick the common bile duct, some jaundice can develop. You watch for sites of infection. You should sort of go through nursing process for the patient undergoing surgery of gallbladder disease, just so you kind of know what to look for following that. But typically it's an easy procedure. And afterwards, for the first like the first few days after surgery, they should still stay on a low-fat diet, but high carbs, high protein, because you want the calories. Because anytime somebody's in the hospital or had surgery, their metabolism will increase, so you want to support that with enough calories and protein, which supports healing. But after the person's been home for 4 to 6 weeks, they can eat, you know, the low-fat diet restriction is usually lifted, because the pain is from the squeeze in the gallbladder. They don't have a gallbladder anymore, then what happens is the liver that makes the bile just dumps it right, you know, from the common bile duct, just without having the gallbladder there. Okay, pancreas stuff. The pancreas is a really funny little organ, but it produces some really, really powerful enzymes that are needed to break down some of the foods that we eat. The problem is pancreatitis, which is an inflammation of the pancreas, is really painful, and it can be fatal. But your pancreas sits right about here, and they think what happens in pancreatitis is that those enzymes, which are supposed to go through that pancreatic duct down into the GI tract to break down food, starts leaking. It gets inflamed and leaks, and then it kind of auto-digests itself. So those enzymes, which are supposed to go through into the GI tract, get out onto the skin or the body of the pancreas and start eroding it. It's very painful. The treatment of choice is NPO, because if you can get the person to stop eating, then those enzymes aren't excreted, and you can just rest that pancreas. Oftentimes it's caused by alcohol, so people that consume a lot of alcohol tend to develop pancreatitis more than people who don't. People that have gallstones can also develop pancreatitis, so that's, you know, you need to rule that out as well. And the things you do have to watch for when people have pancreatitis, because your pancreas is here, once it starts getting inflamed, you do have to watch for respiratory complications, because it's right underneath that diaphragm. It can cause some respiratory problems. It can cause GI bleeding. It can cause sepsis. And it's really painful. So, pancreatitis, what else do I need you to know about that? Go over the clinical manifestations so that you know what it looks like if somebody shows up with pancreatitis. Your amylase and lipase are your, I don't think your book tells you this, but amylase and lipase are your two predominant lab values to watch for in your patients who have pancreas disorders. I don't think your book talks about amylase and lipase. Maybe it does. I don't know. I'll find it in here if it does. Okay, so your role as a nurse and somebody who has pancreatitis is pain management, because it's painful. Good nutritional support. Usually they have to be on TPN and lipids because they, you know, you need to rest that pancreas. And it can, if it's not under control, it can kill a person. And there can be a lot of complications with it. So read through the rest of that with pancreatitis. Pancreatic cysts, pancreatic cyst, that's not super common. I do want to bring up cancer of the pancreas though. Pancreatic cancer is very deadly. Really, if your patient gets pancreatic cancer, it is not good news. It's very aggressive. It often, you've got the head of your pancreas, which is the part that dumps into the GI system, and then the tail of the pancreas, which is over here. Usually by the time a person has any symptoms that they have pancreatic cancer, the cancer is already spread. Especially if it's in the tail of the pancreas, because if it's in the tail of the pancreas, then it does not compress the pancreatic duct, and the patient doesn't get jaundice. If it's in the head of the pancreas, it compresses that bile duct, or the common pancreatic duct, and the patient will get jaundice, and that's a classic, symptom that usually makes people come in and seek treatment. So patients who are developing pancreatic cancer have pain, jaundice, weight loss. Once again, weight loss is really common in patients who have cancer. And then they're not entirely sure what causes it, but again, cigarette smoking, exposure to toxins can increase the risks of pancreatic cancer. Some diets that are high in fat see more pancreatic cancer. It's men seem to have it more than women, and if they can get to it soon enough, they will do a what's called a Whipple procedure. The other things that might show up in your patient who has pancreatic cancer, and I think your book goes into well, it just says sort of like tumors in the head of the pancreas, and I don't think it distinguishes between head, like doesn't say anything about the tail, but in the head of the pancreas, I think I already told you that it obstructs the common bile duct, which is going to then lead to jaundice. Patients, because it obstructs the flow of bile, it can also cause clay-colored stools. Clay-colored stools will occur because bilirubin, like I said, I think I told you this in the other liver one, the breakdown of red blood cells, the heme part that conjugates the bilirubin, makes the brown part, makes the stool brown. When you don't have that, your patient is getting jaundice, then the stool isn't brown, it's clay colored. So usually when you see jaundice, especially in severe cases, and the stool becomes clay colored, you know that you've got high levels of bilirubin that's not getting conjugated. The other thing that you'll see in your patients who are developing pancreatic cancer is they're not able to absorb food because those enzymes that are supposed to be produced by the pancreas are not. So they have a lot of bloating, malabsorption of food, itching, a lot of itching because the toxins start building up. So the treatment of choice is this procedure called a Whipple procedure. And it's, I used to help the guys at U of M and going on some of these Whipple cases. They take 5, 6, 7 hours to do. It's major reconstruction. But sometimes if you can get the cancer in the head of the pancreas, if you can remove that, and you can see here, look down in figure 50-7, what they do is they resect the head of the pancreas that has the carcinoma in it, meaning the cancer, and they put the common bile duct, they suture it to the side of the jejunum, and then they retach part of the stomach to a lower portion of the jejunum, and you can see, compare the top one to the bottom, and you can see what's involved in, like, they take out part of the stomach, they take out part of the pancreas, they reattach the pancreas to the part of the jejunum, and have to reattach the common bile duct. So it's very extensive surgery, but it's usually the only way that you can save somebody's life if they have malignancy. And then if they found the pancreatic cancer and it's already outside the pancreas, then they'll do palliative care where they'll do radiation to maybe try to shrink it so it doesn't hurt as much. But usually at that point it's palliative care, unfortunately. That's a horrific disease. Pancreatic islets of Langerhans tumors, the rest of these you don't need to know. They're very, very rare. So, okay, that's it. That's all I need you to know about that. So then next week we'll do reproductive stuff. We're almost done. Okay, see ya.